to let you know, Sadaf, I've missed you too. Guys, I'm not quiet on purpose. I'm just waiting for my co-presenter to join so that I can actually add him. I might have to ring him and say to join the live. There we go. Hello.
Hi.
You okay, Anthony? Hi, you okay? I think we're all tired today, aren't we?
No, I'm good. I'm good.
You good? Did you have work today? Did you work?
Yes, I did.
Yeah.
Not a big shift, but yes.
Yeah.
I cannot see myself. That's the thing. Just a
Are
second.
you doing it on your laptop again or on the
No, no,
computer?
no. I could not.
On your phone?
I could not.
It's been a while, you can tell, isn't it, that it's been a while since we've done this. But before Unsuman comes back, today we are going to be talking about why general practice. I get this question a lot. Why GP? Why not, hospital medicine? Why not surgery? And we're going to talk today about, why we love general practice, what makes it a good specialty to go into, and why a lot of more people should consider it and stay in the profession. Let's see if he joins now. I think he's probably logged on and now he's going to log off again. Thank you so much, everyone who's joining. It's nice to see people. Hi, Esther. This is a bit awkward. Just be quiet. I'm just waiting for him to join. It's been a while, 5 minutes. Is he on or not? Oh, there we go. There we are. Oh, is that better now? Can you see yourself and me as
Yes.
well? Yeah. What happened? What was the reason for that?
I don't know. It got stalled actually.
Oh, okay. I was just telling them when you logged off that the reason why we're doing this live is we're going to talk about why general practice, why we love it so much, why it's such a amazing specialty. Because it's a question that I get asked. Do you get asked as well? Why general practice?
Yes, actually, get asked a lot why general practice, and I feel there is not a very good idea outside general practice what it is. like not even doctors who are not in general practice, they don't have any idea what happens in.
Oh man, he's about to say something, I think something really important, and then it's gone off. I agree that a lot of hospital doctors may not have had some training in general practice, so may not know what it entails, what the demands are. The only communication we get is through letters, and when we refer. So I think it's important that just like we have to do as GP trainees some experience in hospital, then and having gone through that foundation training in hospital, that hospital doctors should all go through a rotation of general practice, no matter which level they are. I don't know what people think about that. Yes, I have no idea what's going on with Unsuman, but let's see whether he can join. I'm so sorry about this, guys. So what do other people think? I don't know, whoever's on the live now, think about hospital doctors doing general practice, a rotation, every single specialty, whether it's surgery, medicine, you know, even in, you know, occupational health or whatever. What do you think that they should do general practice rotations in order to get a feel for what the demands are, how difficult it can be? And would that then make complaints a bit less in terms of what we refer in, or what do you guys think? He's sent me a request, so let's see. Accept. Yeah, so Unsuman, you were saying about hospital doctors don't understand. Yeah.
Yes, the hospital doctors and anyone who has not watched us or witnessed us work, they do not have any idea at all what we do, what happens when you know, someone comes. Like, I remember from my training days that in the hospital, those who are not GP trainees, they would tell us, "Oh, GP is so good. You just refer." And some of them, they go on to become you know, big doctors, like you know, consultants and all. So just imagine how they look at communication from us, if they grew up thinking that, okay, GP is sitting somewhere, patients coming in, and we either tell them to buy something over the counter, or the other option is just tell them to go to hospital. So no, not at all, not at all. I would say you know, like we probably should come to this later, how to change perception. But I think unless someone spends considerable time, like shadowing or following a GP's life. You have you watched the program GPs Behind Closed Doors?
Oh yeah.
I think those kind of things, they can help people understand what it is.
But I think that program is in some ways dramatized a little bit. I think the best experience is when you're physically in that environment, because you don't appreciate the time pressure sometimes. But I have to say, I was thinking about this because I did a podcast with a medical student, and she mentioned that you only have 10 minutes, and you have to see so many patients. How do you manage that? And actually, during our training, we get that training, how to take a focus history. I think in hospital, when I was doing A&E, you have your pro forma, which goes through all the systems, so you don't miss anything. Whereas in general practice, you don't have a pro forma. The patient is your pro forma. They tell you a problem. You've got to take a really focused history and try and go down that route. I think not missing red flags is very important. And that's what we get taught, that we don't miss the things that may need to go to hospital. But we get very good at that. And I think that's the thing that people don't understand, that we have limited time. but we work hard, you know,
Mm.
we do.
Not only that, what I feel is, yes, we ask some patients to go to hospital. Some patients
Yeah,
we refer to hospital, not acutely, but urgently, and some people chronic, like non-urgently. Uh, but against each such referral, how many patients we manage ourselves? Now,
quite a lot.
that is astonishing number. So, say
Yeah,
you call a particular department in the hospital for an urgent referral or a discussion, and you get a response like, "Oh my God, GP has called again," but
mm.
you probably is calling that department just the one time in last 3 months.
Yeah, I
So,
agree.
but you get that kind of response or vibe. So, and that is there everywhere. And then uh, our patients, they know what we do, but the
Yeah,
problem is we are reachable. So
mm.
they can get appointment with GPs. They cannot get appointment with hospital doctors. So when they go to hospital, they don't want to. Most of our patients, they tell us, "No, doctor, I don't want to go to hospital. You do whatever you can do." Okay.
Yeah,
So sometimes we tell them, "Yes, I know, but what you have, I think this is for best, keeping best interest in mind. This is the safest option for you. You need to
mm.
go and you need to have this." And then that patient goes to hospital, say for a chest pain, and then in the ED, that patient has trop, and patient has ECG and D-dimer, and the patient has chest X-ray, and then the patient is told everything is normal. Your GP should not have sent you to ED, and the
Yeah,
patient is convinced that, oh, my GP could have done this. So um, I think that's how our patients also, they sometimes don't realize what we are trying to do, and part of the blame lies with us. I always try to communicate to the patient properly that this is
yeah,
the reason, this is why it cannot be done. I cannot do a trop. Even a normal ECG will not rule out a heart attack. Only a serial trop would do, and that can only be done in the hospital. Uh,
yeah,
so that those kind of things. But I think it's a poor perception. Um,
yeah.
um,
I mean, if you ask my husband, yeah, he's not able to join the live because he's on call tonight. Otherwise, normally he joins and he asks loads of questions. But basically, there's the perception that we have long lunch breaks and that we have like 4 hour lunch breaks and
I
we don't
don't
see, oh, we
remember.
just sit in an office. And I mean, yeah, we do have a room and we do see patients pretty much all day. I have explained to him it's very different to what his clinics are like because he knows what's coming in. We have no idea what's coming in. And that's what the beauty of general practice is, that your mind could be looking at a mental health case first, then suddenly a patient comes in with shortness of breath and you end up realizing they're in new AF and you've got to refer them in. Or there's a baby that comes in and not well, or, the range of people, conditions you see. And what I love about it is it's all detective work because you don't have the facilities that hospitals have, to investigate patients. You've got to be really good with your clinical examination and be able to work out what's going on. And the communication side, absolutely. I think 80% is how you communicate. I think the 20, the examination and all that comes in with it. But if you don't communicate well, the patient's number one not going to be compliant with medication. The patient's not going to go away satisfied. Like you were mentioning about patients not wanting to go to hospital, not understanding, then getting the communication, oh, your GP shouldn't have done that. And I think when I do refer, for chest pain, for example, I always say this might not be an MI, this might not be a heart attack, but we can't be sure. I haven't got X-ray vision. I can't do your bloods here. So giving them that idea that it may not be that. So if it doesn't turn out to be that, then they're okay with it, even if the hospital doctor says that. They're still on our side, that we did the right thing. So
yes, not all hospital doctors do that, but there are instances when they say after doing everything that, oh, should not have been referred. But I don't mind.
yeah.
End of the day, I'm glad, to be a GP. It's a very satisfying profession, and having that variety, where you see different type of patients, and also you deal with not only the clinical side of things. Then someone has applied to the council to change their house, and they come to you.
Yeah.
You write a letter for me.
Yeah.
I get as that kind of thing. And also when you are able to detect where there is safeguarding issues. So those are things that I'm not saying this does not happen in hospital doctor, but we have larger scope. There is a question, I think,
Yeah. So some GPs say they will only focus on one problem. Patients complain about this. Do you agree as GPs? I understand you have limited time, but do you agree? I've always wanted to ask this. I think you're right. We only have 10 minutes. And to be fair, some patients do ask for more problems to be addressed. And that is difficult. We kind of depends on. I agree with Farah that GP should have longer slots at minimal 20 minutes, but then there's so much demand for appointments that how would we fit in everybody? So the good thing about general practice, you can bring them back. So if they have 10 minutes on one day, as long as the problem isn't urgent, you can ask them to come back.
I think it cannot be blanket 20 minutes, because there are appointments where you can finish within 4-5 minutes also. So yes, 15 minutes is an idea that is being floated everywhere, and I think 15 minutes is a very good idea. But yes, some can be done in 10 minutes. But when you were talking about the documentation and thinking about that 5 years later, you are sued for something, and because of lack of time, you did not document properly. So it's
because that 10 minutes is where the patient has to walk in, be examined, management plan, and then you have to write as well. And I know Farah has mentioned that if you have a practice pharmacist, I mean, the practice that I was at used to have a practice pharmacist, and he dealt with all the medication queries. We didn't have much at all, but obviously when he was on annual leave, it was a bit of a nightmare. And we do have a nurse, and we have quite a few nurses who do prescribing as well, and they can see patients with sort of acute problems that but I don't think it's to do with that.
I want to say something in this. So if you are trying to think that, okay, having some nurse practitioner, pharmacy practitioner, they can sort this problem, that points to one very, very important thing. That is, we are short in workforce. That means we need more GPs. There is no doubt about that. That's why we are thinking of, can we get 2 NPs, because we are not getting enough GPs. So I think it's a question of long-term investment, where we get more doctors and more GPs, and then also we need to have more GP surgeries, because there are GP surgeries where they cannot provide enough rooms. Like if you add 2 more GPs and they want to work, more days, they will not be, many GP surgeries will not be able to provide a room. And they say, no, you cannot work on Monday because our rooms are all so that kind of thing. So so more GP needed, definitely. 15 minutes consultation is a thing, but that cannot sort out, because there are patients who would be coming up with even 4 problems. And some patients, they try to say, I have seen that they try to say, oh, I think all these are related, and they tell you about 4 very different problems, and they try to get those sorted. And also, Zainab, I think you also explained that sometimes they tell you about a skin problem, then they tell you a nail problem, and then you think, okay, fine, I have dealt with 2 problems, and then you have a couple of minutes left, and then they say, yes, and I have this knee pain, and you think, okay, fine, I have done three things, and then before leaving, they said, I have one more thing, and you say, sorry, I cannot. I cannot accommodate any more. And they say, actually, I have this chest pain and shortness of breath. So you increasingly coming across those who will not say anything. And if they say that at the first thing, because they know that is the most important thing, that's why they leave it for the last. Because otherwise, we would say, like, okay, let's deal with the chest pain today, and then leave the others. So sometimes it is difficult. I'm not blaming them, but I think this is another thing that I'm seeing increasingly. Like,
I mean, I had a patient recently who sort of came in with saying that I've been told as a new practice patient that this appointment is to tell you all about all my problems. And I was like, okay, I have 10 minutes. And then she said, do you want me to come back later because I can wait if you want? And I was like, oh no, it doesn't work like that. I think they were, from somewhere where they have private healthcare or something. So there's different perceptions of what we can, what we're able to do. We're able to do a lot of things for patients, but it may just require them to come back. And I think that conversation I have with a lot of patients, listen, what's the most pressing problem? Well, let's deal with that today. This. Let's deal with this one today, then we'll do that one next time. And making sure you keep them engaged, because you don't want them to go away feeling like you didn't do something for them. I think that's what's important.
also about saving time, we always learned that, okay, you ask an open question, and there is golden silence. So you ask, how can I help? And that's a minefield. I recently started avoiding that, and I'm very blunt sometimes, like when there is a proper booking note, I straight away go to that. I say, okay, have a seat. It is written in the booking note that you are here for this. Is that right? So that helps. If there is a booking note, that helps me to get out, like, okay, I'm seeing you for this. That is an indirect proposition. And then if the patient says, and there is this also, then we can always say, like, okay, let's see what we can do about it. But sometimes I do that, no open question, because of this. Because you cannot do that open question. Open question is a minefield. It's cluttered. Every consultation would be.
But it depends on the patient, because some patients know they booked in for something, and so they will say that, and they will mirror what the receptionist has written. I know Farah's written here that they have in West London, they have a hub setting which works really well for GPs and allows them to see more patients. Just want to say, Farah, how does that work? How does that work by having a hub? Is it separate? Do the GPs go there, or like, as in, is it the same GPs at the practice? But yeah, so I think overall it's a very demanding profession. People don't realize that, but it is very rewarding as well.
Yep.
Yeah. Farah's asking if she can come live.
Yeah, I think so.
Yeah, should we invite her?
Yeah.
Yeah, let's invite Farah.
Shall I shall get me out.
No, it will be fine. It will be fine.
Okay.
It'll split the screen. Oh, assalamu alaikum, Farah.
Walaikum assalam. How are you?
Yeah, good, thank you. How are you?
Yeah, alhamdulillah. Yeah, good.
Oh,
I was just intrigued. Hi, hello. I was just intrigued with your live, so I thought, it's quite interesting what you're talking about today.
Yeah, I mean, we've had few sort of negative perceptions about general practice. in the past. And I think we wanted to sort of lay down some ground rules as to like, okay, GP is very difficult, but it's a very nice profession. The hospital doctors tend to have a different view. They think that we just refer everybody, but we tend to deal with a lot of stuff in general practice. So we were just talking about how general practice is very good and enjoyable, rewarding.
It is.
But what
It
are
is,
your
yeah.
what are you doing at the moment?
So so I'm a medicines optimization pharmacist. So I
Yeah.
work for community healthcare now.
Okay.
So my obviously, as you know, I've been in hospital for most of my career.
Yeah.
And then I went to PCN, which was okay. It was more, for me, it wasn't a good experience. But then now I'm kind of like in the middle. So I've kind of like, I work with the GPs very closely.
Yeah.
And with the GPs, it's quite nice because it's like you can understand what they're doing, what they have to go through. And then I then obviously do work with secondary care as well. And then we
Yeah.
see some complex patients. So at the moment, like, so obviously my background's geriatric medicine.
Fantastic.
And so I see a lot of care of the elderly patients. And what we do here is it's actually worked quite well. And one of the GPs said actually that they're actually seeing more patients, the ones with like, complex comorbidities who've got
Yeah.
lots of health conditions and issues going on. And basically how it works is, so I look after about 14, 15 GP practices. And what we do is we have
Wow.
each practice, what they do is they have like a hub. So basically what
Yeah.
it is, it's a hub where, let's say, for example, you can have it on a weekly basis. You have a 1 or 2 GPs that are assigned to it, depending on how many GPs you have in that practice.
Yeah.
So let's say, for example, it was yourself. Then you would have a pre-hub MDT. Now, in the pre-hub MDT, you would have a pharmacist attending that. So usually it's myself. The practice pharmacist does get busy with other things. So because I'm from community healthcare, I kind of join in. But practice pharmacists can do this as well. And then you have a case manager, which is usually like background of nursing, who
Okay.
knows the patient quite well. And usually, and it's a GP. So this just us three. And then what we do is the pre-hub MDT is usually about 20 minutes long. And what we do is I do like medication reviews. So what I would do prior to the MDT is I would do a medication review on that patient and see if there's anything that we can discuss. If there's anything that we can, sorry, I'm just going to another room. If there's anything that we can discuss, like, in the hub. Now, at the moment, this is all remote. So I'm doing this remotely at the moment, and I usually just spend about, depending on how complex the patient is, about 10-15 minutes just reviewing the patient's medication. And the nurse will also bring up any issue that's going on with that patient. And then what usually happens at that point is that the GP can actually have a look at the medication side of things and say, okay, like I've recommended this, for example, why
Yeah.
isn't this not reviewed? So it's like a quick review, and then that patient then comes into, then you have your hub. So let's say you have your pre-hub, let's say 9 o'clock in the morning till like 9:20, and then your first patient comes in at 9:30. So it depends on how many patients you want to get booked in. So you could do half an hour slots, 20-minute slots, depending on the complexity of the patient. And then you're just literally doing half an hour slots. So you have like 4 or 5 patients booked in, and literally that patient is thoroughly reviewed. Like the bloods are done.
Right. Yeah.
You've reviewed them. You've had a pharmacist who's done all the medication review, and then you've kind of addressed all their needs. And then basically that patient does not need to be reviewed for like at least, depending on what the outcome of the review is, 6 months to a year. And what they were finding is that when they were doing this, they were seeing more patients in a short period of time, and they were addressing it. They only spent probably about half an hour per patient, and they were addressing more stuff like with that patient rather than booking several appointments, like 10 minutes, 10 minutes, 10 minutes. And they felt that that was much better for the patient.
And this is
So,
just chronic conditions then, so or just elderly patients, because I suppose a lot of patients don't need half an hour. Do you see what I mean?
Yeah.
So like they're just people that would have complex needs, or that would be booked into those hubs, and then everyone else who's got acute problems can just be seen at the practice.
Yeah, exactly. Yeah. So these kind of
Sorry.
patients who I've been seeing are obviously got the different types of frailty. So I see mild, moderate, severely frail, and they're the ones that tend to be the ones that've got the chronic health issues and a lot going on with them. So they're the typically type of cohort of patients that come in and get reviewed in these hubs. And then you've got, but then you can get, like, for example, I had a patient who was 54 years old, but no kind of frailty assigned to that patient. Doesn't come under elderly, but it was very complex in the type of the conditions that he had, and he wanted to see if we could help him. So I remember I did a medication review on him. I think I spent about 20-25 minutes doing that review, and then literally, like, all the issues that were going on with that patient was discussed in that hub. And you know, we just went through each by one. So, and then the pharmacist doesn't have to be present at the hub, because then the GP can just address those issues depending on what we discussed in the outcome from the pre-hub MDT that you kind of have. But it's like literally, so depending on the size of your practice, like patients wise, it depends on how many times a week that you do your MDT. So, like, for example, the bigger surgeries, they do theirs twice a week. Some surgeries just do it once every 2 weeks, maybe once a month.
And this
sometimes.
is why we need more GPs, because if, say, for example, one of us was free to go to one of these hubs, it would make, you know, I would lose doing a 10-minute appointment surgery where I'd see 15 patients. Do you know what I mean? So it's like I'm going to be taken out of that position where 15 patients would normally be seen to, you know, 6-7 patients are being seen. So they might see that as not as very cost effective. So you need more GPs, I think. We do, definitely. Especially in this area. And London is probably a good, you know, there's probably, do you find there's a shortage of GPs in London?
I mean, at the moment, they've not actually said anything about a shortage wise, but what they're doing is that they usually have just the lead GP or the kind of the, or a regular GP who does these hubs. Now, sometimes what happens is obviously, you know, some people are not, like, annual leave and holidays and sickness and whatever. So what they do is they do a rota. So a couple of practices do a rota. So then each GP is interested in doing it. So then they have a rota of, like, okay, this GP could do it this month, another GP could do it another month. But it all goes down to how many GPs are covering in your practice. So if you had, like, let's say on a regular basis you have like 4, then you could take one GP out to maybe see all the chronic. And you can get, like, do you use System 1 or do you use EMIS? EMIS. So on EMIS as well, I think I use System 1, but on EMIS there are searches that you can do to find all these patients with the chronic health conditions or ones that need reviews. And if you have a practice pharmacist, and they can help you in, like, identifying, like, a list of patients, and then you could trial doing the hub and see, is this more effective? Because we found, well, I've been doing it now for a long time now, and I'm finding like the GPs have given really good feedback that they're actually seeing those patients that they haven't seen in, like, a couple of years. And sometimes, like, some patients get often missed, because, like, I remember I went to go and see a patient who's 93 years old, doesn't usually go and see the GP, but he's only just been identified to be seen by the GP because he's still driving. And he's 93 years old, and
that's pretty awesome.
And he's been, like, stable on his meds for the last, I don't know, 10-15 years or whatever, but he's not been regularly reviewed. And then now when I've come in to see him as a thorough, like, I've done a completely different review. It wasn't part of the hub, it was actually a home visit that I did for him. But there was, like, so many medications that were given to him that could have been, like, stopped a bit earlier. And also, like, a habit is that when patients are stable, you then tend to, like, increase the supply. So you tend to give like 3 months at a time, or 2 months at a time, and then they often get missed off. But then, like, these patients are now being identified, and now you can, like, you know, you can just kind of, like, take them off, right? Okay, I've seen this patient, they've done a thorough review, we've rationalized most of the meds that we feel like he doesn't need to be on, and then now he doesn't need to be reviewed for some time.
But it's so good, like, you know, in general practice there's a multidisciplinary team, if you think about it. Like, you as a pharmacist add so much value, then we've got the nurses who add so much value. So you are part of a massive team. And I think you feel there's that perception that you're on your own in that room, there's just you and the computer and the patient, and that's it. But it's not. There's a whole team of people that are working together to help this person, and I think it's amazing. I really do. I mean, we do have care home reviews and things like that, so we do have slots. Some GPs do just focus on we're looking at patients in care homes for that afternoon, for example. And that could be part of chronic health review as well, especially because many of them are frail and elderly. But the hub sounds really good. I think when Miriam was saying on the chat that the hub sounds like, you know, what will this idea be spread across the UK?
I hope it does. I'm
I hope,
not sure. I mean,
does.
yeah, because I mean, I know that I don't know if it's just in London, but I know, like, I'm part of a trust that does community healthcare, and we're doing this as part of the community healthcare.
Yeah.
So it really depends on other trusts. If like in your area, is there a community healthcare trust? And if there is, do they have somebody like that? Because in the community healthcare trust, you would have medicines optimization pharmacists, you would have, and they're usually from the CG and stuff, and they're the ones who may get involved. So it could be something like that they get involved in helping, like reviewing all your patients. Now the team that I'm talking about, where we have a case manager, it's usually called My Care My Way, which is basically a team that is led by nursing background, you know, case managers. And they're the ones, the nurses are the best people, because they're the ones who go and see these patients at home. It could be like social, because of a social reason, or they've been involved, like not for medication related clinical issues, but just other things. And then they also then feel like, oh, actually, you know what, it'd be nice for a GP to review this patient, because actually they might be struggling. Because when you start seeing patients in their home environment,
it's
then
totally
you're like, it's totally, isn't it? Right, exactly. And then, like, you know, you don't understand like what's going on. But then when these nurses are going to see these patients at home, they think, actually, you know what, I think this patient would need to be reviewed. And then you'd be surprised at what you can come out with. But yeah, it's like it's been really good. It's like it's a lot of patients. Like, I remember, I think, so I look after about 15 practices. So, and I think the most reviews that I've done in 1 week is about 90 something. So that's 90 something patients I've reviewed, medication wise, that we've seen. So that's imagine that's 90 something patients I've seen in a week. Across, pretty much.
That's fantastic.
So
it's good to see that you're doing well, and like, you know, it's been a long time since I've seen you. You know, it's been many years, and it's good that you've joined the live. Like, it's been really interesting. I mean, whether anyone else would like to say some positive things about why GP, why be a GP. I think part of being a multiple, like part of being a part of a team, also, you know, seeing the varied cases, the ages that you see, from pediatric patients to elderly patients, the different conditions that walk through, is like no day is the same. It's fantastic. You agree with me, don't you, Ansuman?
To be honest, give credit to you guys. You don't know what's going to come through the door. I heard that part, and I was like, that's what makes it fun, I guess, for you guys. So, but no, I think that's the problem, because, you know, these patients get admitted to hospital. Credit goes to the hospital people, because obviously they've treated that patient. They send them out into the community. But you guys are the ones who actually take care of the patients, technically. And
well, we all do. We all do. You as a pharmacist, the nurses, us, you know, we're all a big team. The reception staff, everybody, you know, who is part of the community is, you know, doing an amazing job. So it's good to be part of the community, I feel. Definitely. Go on, Ansuman, were you going to say something?
No, not much to say, because talking about general practice, it would not be one evening or one night. It would be a lot.
Well, you know, we're going to do more lives after Ramadan. We're going to do more lives with various other GPs who are doing lots of things with post qualification as well, and showing that even if you know, I know people say being a GP is just enough, to be fair, but as GPs we like to wear different hats. I don't know if other people agree, but we like to, you know, like some people want to be teachers, some people want to be trainers, and these are the things that we can add to spice to our career. So we can do different things. You can tailor your week, basically, work less or work more, whatever you want to do, and help others as well. So that, I think Fatima Al Ghazawi, Dr. Fatima, she's going to be talking to us in May about being a trainer, being a TPD. And also she did the PG cert as well, so that'll be quite an interesting talk to find out how she did that. And did you have any questions, Farah, to us?
Oh, no, I mean, it was just honestly, I've got to stress, like, I work with GPs now very closely, and I've got to say, you guys hats off to you guys, like for seeing so many patients and getting through everything and then actioning everything and then chasing up. You guys have so much that you've got to do, and I don't think enough credit goes to you guys, because a lot of complaints are, oh, there's not enough time, and you have to give us more time and stuff. But no, I'm just gonna say, you guys, just credit to you guys, because you honestly do a lot.
Oh, thank you, Farah.
I don't think people can notice that enough. So yeah.
Yeah, thank you so much. Do you want to add anything, Ansuman?
No.
No, he's just like quiet now.
No, because it was very absorbing listening to Farah. So it was nice.
It just shows what things you can do to try and improve care and be on the forefront of it. So I'm excited to try and do something further in the community to try and help us take care of our patients. One of the ideas I do have at my practice now is doing some sort of videos about how to use different healthcare settings. So when do you go to a walk-in centre, or when do you go to your GP, or when do you go to A&E? Because I've got a friend who works at the walk-in centre and is nurse-led, but a lot of patients don't know that, and they will go there with chronic back pain or chronic leg pain, and they can't deal with that sort of problem. So we need to sort of educate patients how they use different services, basically.
Yeah.
So yeah. Oh well, I think we've done our bit. Let's thank you, Farah, for lightening up our live as well and joining us. Hope you take care and keep watching our lives when we come on next as well. And thank you, Ansuman. See you soon.
All right, take care. All right,
you too. Bye. I'll save this live now. Okay.